Hello, everyone. Welcome to Preemie Chats today. I'm glad you can join us. I am Leah Whitehead. I'm a preemie parent and a volunteer with the Canadian Premature Babies Foundation. Canadian Premature Babies Foundation is also very well known as CPBF, and it is a charitable organization. Its mission is to support and educate Canadian families of premature babies. And this Preemie Chat series is just one of the many ways that CPBF shares information with NICU families and healthcare professionals. Here, every Friday, we talk with medical professionals, researchers, and parents who share with us their NICU experience and knowledge. And we want you to be part of the discussion today too. So please leave a comment. Let us know that you're watching and ask questions as we go about today's presentation and discussion. Be sure to check out CPBF's website. It's there on the screen, canadianpreemies.org, and there you'll find all kinds of resources and support. Parents are the most important people and intervention a baby can have in NICU. But NICU families know that it can be disorienting to be there. And so on this website, you'll find resources like the video series, Welcome to the NICU, that hopefully once you watch, you feel like you know just a little bit more about NICU and your invaluable role there as families. And right now, in the face of fears and anxiety brought on by the COVID-19 pandemic, CPBF has put together the Parent Care Program, and they offer 4 therapy sessions for families currently in the NICU or those who have been discharged up to 3 years. So check out their website, canadianpreemies.org. Now to today's topic. What is BPD, or bronchopulmonary dysplasia? We're going to hear about what it is, where its definition comes from, and the impacts of lung injury in the longer term. We'll also hear about what we know right now about how to prevent lung injury. And leading the presentation today is Dr. Keith Barrington. He's a neonatologist and a preemie parent himself. He practices at Sainte Justine Hospital in Montreal and is a professor of pediatrics at the University of Montreal since September 2008. He's published over 220 peer-reviewed papers. He's an active member of the neonatal review group of the Cochrane Collaboration, for which he's published 8 systematic reviews and updates. In addition, he's an active blogger at neonatalresearch.org. His research interests are in apnea and respiratory control, in cardiovascular adaptations and circulatory support, reducing lung injury, in ethical decision-making, and in any clinical research in neonatology which might improve outcomes. Thank you so much for joining us here today, Keith.
Well, thank you. It's a great pleasure and a privilege to be presenting today. I hope I haven't bitten off too much more than I can chew with the thought of trying to both define and prevent BPD in 20 minutes, but we'll try and hit some of the highlights.
Sounds good. I'll let you get to it.
In fact, one of the things I wanted to do right at the beginning was to show you this image which is behind me. This is, as Leah mentioned, I'm the father of a preemie. My daughter Violette was born at 24 weeks and 3 days, I think. Weighed just over 700 grams, and she's now going to junior college, what's called CEGEP in Quebec. And one of her projects there, which is an art project, was to do something about fragments of history, I think it's called. And so what she's done, I'll just move my camera for a second. I don't want to make anybody sick here, but you can see here that behind me is her project, which has her lungs. There's pictures of her as it's hard to point. That's Violette on the first day of life, and there she's used some of the equipment that was both at that time, and then when she went back and had to have airway surgery a couple of years ago, which is shown by the pictures over here when she was in the pediatric ICU with her being intubated again. So she's been through quite a lot, but she's doing really well. And I'm very proud of her. I'm proud of what she's done with this piece of artwork, which uses nasogastric tubes and a defibrillation pad and all sorts of things. Violette, in fact, did have some lung injury, but she came out of oxygen when she was in the neonatal unit at about 35 weeks corrected age. So according to the official definition of BPD, she didn't have BPD. But when she went home, she was still breathing fast. She would still cough easily. She actually had a bit of airway problems that got worse when she was a teenager, and which is why she had to have that surgery a couple of years ago to open up again her airway, her larynx that was narrowed by the tube that had been put in there when she was a newborn. So talking about lung injury in the newborn in the preterm for me is, as for many of you, is actually quite personal. This was actually first discovered or described in 1967 by a paper in the New England Journal by a pediatric radiologist called Bill Northway, he's the one who came up with the name as well, called it bronchopulmonary dysplasia right from the start. And he described these 4 different stages of BPD, which is first hilar membrane disease, and the lungs clear. And then this is a picture from stage 3 from his article, where you're starting to get a lot of inflammation and fibrosis in the lung. And then you finally end up with these permanent scarring in the lung, which he called stage 4 BPD. Now, his initial paper was just a description of what was happening to these babies. And in fact, what's one of the many things that's interesting is when you look back at 1967, the babies that he was reporting on had been born in the early 1960s. And these were babies who were being ventilated for the first time. Before then, we never used to put babies on ventilators. And the babies were being ventilated with ventilators designed for adults. There was only one kind of ventilator that had been designed for adults. They didn't have any PEEP, any positive end expiratory airway pressure. The babies were usually in very high oxygen concentrations because there was no way to continuously measure their oxygenation. And if you sent off a blood gas, you usually had to wait the next day to get the results back. So the baby didn't have many blood gases. It was all done clinically. And if the baby went blue, you turned up their oxygen. And if they stopped being blue, you left the oxygen at a high level. So a lot of the babies had a lot of lung injury just trying to keep them alive. And many of them did survive because of the assisted ventilation. But when we're thinking about things that are more recent, we have to sort of think about the more immature babies that we're now looking after. And when the babies are born very preterm, their lungs are still developing. In fact, the most immature babies are only just starting to develop the air spaces where they can exchange oxygen and CO2. These respiratory bronchioles, they actually don't have any alveolar sacs. They don't have any true alveoli because they don't appear till term. And in fact, what should be happening for a fetus who's very preterm is that their lungs should be filled with fluid. Fluid that's actually created by the lungs. It's at very low pressure. There's very little oxygen in that fluid. And the baby the fetus before birth makes these breathing movements where the pressure in the lungs goes up and down, but there's no way for the lungs to get over distended. Even if the pressures might occasionally go up to just as high as 10 millimeters of mercury, or about 13 centimeters of water, the lungs never get over distended. So the lungs are actually able to grow happily in utero. But when the baby is born, and they're born here towards the end of the canalicular stage, it's called, when you've got these canals just forming in the lungs, they actually don't really have many of these alveolar sacs, as they're called, these little things that are developing on the end of these airways, which are older preemies or more mature preemies rely on those. And then the true alveoli and the really good lung structure start to develop when the babies reach term. So when we're looking after babies of 22, 23, 24, 25 weeks, they're really at a very immature stage of their lung development, and we're exposing them to a very abnormal environment. So I actually don't think it's ever going to be possible to look after babies on a ventilator without some sort of lung injury, because it's such an abnormal thing that we're doing to them. But what we have to do is to try and reduce that injury as much as possible. What are the things that we can do to reduce that injury? Well, we don't want to stretch the lung too much. We know that stretching the lung and over distension of the lung is the thing which is most damaging. But we also want to prevent atelectasis, when the lungs completely collapse down at the end of a breath. Then you have to use much more pressure, and there's a lot of shear forces in the lung when you try and open it up again. So we really want to stop the lung completely closing down at the end of expiration. We also don't want to give more oxygen than we need to. So you just give as much oxygen as you need to keep the baby healthy, but without giving them too much, because oxygen itself causes inflammation in the lungs. And infections are really bad. Both infections in the lung and infections elsewhere in the body increase inflammation in the lung and will make the lung injury worse. I'll just skip over those next slides. I've decided not to talk about that. But so what can we do to reduce lung injury? What actually works? Well, there's actually, when we look at the medical literature, and this is something that I've been studying, as was mentioned by Leah, for the last 40 years. I've been doing studies trying to figure out how to best improve lung development in preemies, among other things. And one of the things that we now know is that the best thing you can do is not to ventilate babies. And there's a few studies where, instead of doing what we used to do at one point, which is as soon as a small baby was born, we'd put a tube into the trachea, give them surfactant, put them on the ventilator. Once surfactant was developed in the middle of the 80s and became routine in the 90s. But there was a couple of studies showing that probably if we wait and put the babies on CPAP first and then only intubate them when they really need it, that you can actually reduce the lung injury. And there's a couple of studies, the COIN trial and the SUPPORT trial are two. And then there's a nice study that was run by Mike Dunn at Women's College Hospital, that I'm not sure if it's still called Women's College Hospital, that they called the Vermont Oxford Network DR trial, which also showed the same thing, that putting the babies on CPAP first and intubating if you need them reduces lung injury. What about other things that we can do? Well, some centers use a lot of high frequency ventilation, the HFOV. And in fact, all the studies that have been done, and there's now about 17 of them that have compared high frequency to standard ventilation, really don't show much difference in lung injury with high frequency ventilation. That was what we hoped at first when we introduced it. In fact, we know that high frequency ventilation leads to more pneumothoraces and air leaks than conventional ventilation. But overall, in the longer run, there's no impact on bronchopulmonary dysplasia, on lung injury, as far as we've measured it. We now, and most centers, when we're using conventional ventilation, will ventilate using what's called volume guarantee. Again, volume guarantee ventilation in the studies hasn't really proven much difference. There aren't very good studies. There aren't very big studies. The trends are all to improved pulmonary outcome. There's a lot of theoretical reasons why we should use volume ventilation, a lot of practical issues which make it a better choice. And I only use volume ventilation except if there's too big a leak in the system for it to work. So again, I try to practice evidence-based medicine whenever possible, and volume ventilation is probably better, but it isn't really quite well proven. We all now also all use synchronized ventilators. In the past, when I started doing neonatology, there was no way to synchronize the ventilator. The ventilator went at a regular rate and the baby breathed whenever they breathed. And we used to have all sorts of ways of trying to make the baby breathe in sync with the ventilator by sedating the babies and putting the ventilator rate up really high so the baby would breathe at the same rate. Since we introduced synchronization, there were just a couple of studies which actually didn't prove much difference in lung injury, but we all now, everybody everywhere uses synchronization because we know the babies are more comfortable, for one thing, and it just makes a lot of sense. No one would ever go back to unsynchronized ventilation. So what are the best ventilatory strategies? Well, the best is to use the optimal PEEP. That is a end expiratory lung pressure, which isn't so low that the airways close at the end of expiration and isn't so high that you need more to over distend the lungs to get the adequate ventilation. But exactly what is optimal PEEP is different from one baby to the next. And this is one of the things that we really need to work more on in neonatology. We know that some babies, before you give them surfactant, their lungs will actually collapse and close. Even if you keep the PEEP at 8, 9, or even 10 centimeters of water. In adults with ARDS, they'll often use PEEPs that are much higher than that. But we have the advantage of being able to give surfactant to our babies. And so it's unusual to need more than 8 centimeters of water before you give them surfactant. But once you've given surfactant, we need to reduce the PEEP rapidly so that we don't over-distend the lungs. And how much volume should we use on volume ventilation? Again, there's not very good data to tell you exactly what you should use. Probably the best guess, and from all of the different studies, is about 4 mils per kilo plus an extra 0.5 mLs, not per kilo, just 0.5 mLs absolute, for the dead space of the endotracheal tube. What that works out to, of course, for a baby of 500 grams is that you're giving them 5 mLs per kilo. And a baby of 5 kilos, you're giving them just 4 mLs per kilo. So the smaller baby, because of the increase in the airspace, needs a larger relative tidal volume, although, of course, the absolute number of cc's is much lower. And in fact, the peak pressure that you get on the ventilator doesn't matter. What matters is that you don't over-distend the lung, you don't overstretch the lung, and you make sure you've got enough volume going in and out of the lung to get rid of the CO2 and to get good gas control, and a PEEP which isn't too high or too low. Probably the best strategy for triggering is to use what's called assist control. In the past, I used to use a lot of what's called SIMV, synchronized intermittent mandatory ventilation, because it was hard to stop the ventilators triggering themselves and auto-cycling very fast. Nowadays, with better humidification system, which give you very little rain out in the tubes and very little auto-cycling, you're best to use assist control, because that will assist every one of the baby's breaths. And you're also better not to use an SIMV with inspiratory assistance, because that is switching back some of the breaths to pressure control. So you're better off to use a volume guarantee mode, and I think most of the centers in Canada are now using volume guarantee, and usually with the Drago VN500. Inspiratory times are something that we haven't talked about very recently because of synchronization, but in fact what we do want to do is to avoid too long an inspiratory time, because otherwise the baby will start to expire while the ventilator is still at its highest pressure. And that actually gives you an asynchronous thing. So you can actually get asynchronous ventilation if your inspiratory times are too long, even when the triggering is working and the baby is synchronized. What else works? Well, vitamin A works, but very few centers are giving it. And that's because the studies that showed that vitamin A supplementation decreases BPD were done in the USA, where the vitamin A status of many of the mothers in the units was much lower than it is in Canada. That you also have to give the vitamin A intramuscularly 3 times a week. So it's a lot of painful injections for babies, so we don't want to do that very much. And it only seems to work for the milder forms of BPD. In a study that's just been published, it didn't actually have much effect on the more severe forms of BPD. So I think very few centers are actually giving IM vitamin A, if any. We're going to try and look at other ways of giving vitamin A, try and give vitamin A in the intravenous fluids, in the TPN. At the moment, it gets destroyed by light and gets oxidized, so it doesn't actually reach the baby. But there are other ways of doing it. Steroids, well, steroids at various phases after the baby is born may reduce bronchopulmonary dysplasia. And I'll come back to this later on in this talk. Late surfactant has been tried a couple of times. So if the baby is still stuck on a ventilator at 2 weeks of age, maybe we should give them another dose of surfactant, because the surfactant they have at that point isn't working quite well. So that's something that needs some more investigation. And then one thing that's coming along right now and is starting to be introduced, I think, in some of the centers, is actually mixing a steroid called budesonide in with the surfactant when you first give the first dose of surfactant after birth. Maybe that will reduce lung inflammation. And the studies currently are quite positive, although there's another really good study going on right now that will actually give us a much better answer, I think, about whether or not giving the budesonide early on in life with surfactant is the right way to go. But what is this BPD that we're talking about? The first definitions after that paper that I showed you at the beginning was developed by a group who said, okay, well, if the babies are still needing oxygen after a month, they've got lung injury, they've got BPD. And we used that definition for probably about 20 years. Then a group in Sunnybrook Women's College, Andy Shannon and Mike Dunn, who still works there, and some of you may know, came up with this idea that maybe we should actually redefine and say if the baby's still on oxygen at 36 weeks, because many of the babies who were born at 25, 26 weeks gestation, they need oxygen for a month. But by the time they're nearly ready to go home, they're just fine. Their lungs are doing really well. So they said, well, maybe it's a more persistent need for oxygen, which is more important. The CNN, the Canadian Neonatal Network, has just published a paper saying that actually probably even more important is how much oxygen the babies need once they reach term at 40 weeks. But really, is that really what's important? I ask, well, for babies like my daughter who's in oxygen at 35 weeks, but comes out at 30 before they reach 36 weeks, and at 36 weeks, they're in 21%. Does that mean they're fine? Well, from my own experience and from the experience of many people, we know that they're not necessarily fine. And we know that some babies who come out of oxygen at 37 or 38 weeks, they do just fine and don't have any big problems afterwards. So what's really probably important to families and to the babies themselves is the respiratory problems they have after they go home. Sorry, I've gone backwards. So I think things that really are probably more important to parents is whether or not the baby needs to go home on oxygen. Do they need to come back to the hospital on multiple occasions, to the emergency room, or to go see the doctor because they're wheezing or coughing or look like they're short of breath? If we need to give them Ventolin every day, it probably makes a difference. And if they wake up coughing or wheezing. So in fact, when you look back at how and why we redefined oxygen, BPD, to be at 36 weeks, it was based not on just an idea pulled out of the air, but it was actually based on what might predict the problems of the baby at long term. And this is one of the tables from the study from the paper from Andy Shannon and Mike Dunn, which show that at 36 weeks, the babies who had an abnormal outcome, a lot of them were still on oxygen. Some of them, even though they had an abnormal outcome, were already out of oxygen. And some of them who had a normal outcome, that's a normal long-term pulmonary outcome, some of them were still in oxygen at 36 weeks. So they knew right at the start that this was not a perfect description of lung injury. And in fact, what they called a poor outcome was all of these different things. If you had any one of these things, you needed oxygen to go when you were at term, if you died from, obviously, if you needed a cricospit or other respiratory surgery, if you were wheezing, or if you had both persistent respiratory changes and you had developmental problems, they said that was a poor outcome, even though that's not necessarily directly related to the lung injury. And in fact, every other study since then that has tried to redefine bronchopulmonary dysplasia has actually looked at the long-term outcomes, different long-term outcomes each time. So the study from the CNN, this is what they looked at to change the definition to 40 weeks, or to think of changing the definition to 40 weeks. If you needed 3 or more times to go to hospital because of the respiratory illness, or if you need oxygen at home or monitoring at home, and if you needed oxygen or CPAP when you were still being seen at 36 weeks, at 2 years, sorry. So each of these studies has actually looked at different long-term outcomes. And in fact, who decided on these long-term outcomes? Well, in each situation, it was actually the investigators. None of them ever asked the parents, what is it that really matters after the babies go home? So in fact, these are the things we've mostly looked at, the things that are sometimes reported: rehospitalizations, home oxygen, and medication use. But I think that some of these other things probably matter to parents as well, like feeding problems, going to the emergency room, having to go back to the doctor's office to visit them, having a persistent cough, baby being short of breath, having to take the baby out of daycare because their breathing gets worse or they start to cough, having to take time off work themselves because they have to go stay home to look after the baby, and baby waking up frequently at night coughing because they've got breathing problems. All of these things, we actually don't know which of these things are more important to parents and which of them are actually affected by the things that we're doing with babies. So what things, if we go back to that list of things that we can do to try and reduce lung injury, I can ask you, well, which of those things that reduce lung injury actually improve these things that matter to adults, to parents at long term, or to the babies themselves at long term? If we give steroids, not just does it decrease BPD, but does it make the children better after they go home? Does it mean they have to come back to the hospital less? And in fact, when I compared in the study we just published, in this little paper we just published, there were 6 trials that I could find that looked both at BPD and they looked at the long-term impacts of the intervention. Here, for example, in the support trial didn't show any effect of the prophylactic CPAP on its own compared to intubation surfactant on BPD. But when they looked at the babies in the long term, the babies who had the prophylactic CPAP were much better. They had less asthma, less reactive airways disease, they had fewer hospitalizations, and they had less negative respiratory consequences reported by the parents. There's here the study on late surfactant that I talked about. So this was a study, these 2 studies here, the Tulsa study and Rose's study. They both gave surfactant at about 2 weeks of age for babies who were still ventilated, and neither of them showed an effect on what we call BPD. That means there were just the same number of babies who were on oxygen at 36 weeks. But when you looked at their outcomes in the long term, the babies who got the late surfactant were doing better. There's some other studies, like if I just concentrate for a moment on the dexamethasone studies, most of the dexamethasone studies, if you give it early enough, will actually prevent BPD. But none of the studies have actually shown that the babies are better in the long term. So even though you've got less inflammation at 36 weeks and the babies are more likely to come out of oxygen, it actually doesn't help to prevent lung injury if you define it by the problems that the babies have at home once they've been discharged. So maybe we shouldn't be using steroids just to prevent BPD. What we should be doing is finding doses and ways of using steroids that improve the longer term outcomes. There's even one study here, which was a study, it's a one-off study of some recombinant superoxide dismutase. And in the original study, they actually showed that this new intervention actually led to more BPD, but in the long term, they showed it led to less long-term respiratory problems. So I think that, in fact, what we're doing at the moment is the wrong thing. We're focusing on trying to reduce what we call bronchopulmonary dysplasia, and what we really should be doing is focusing on how well the baby's lungs are doing, and the rest of them, of course, not just the lungs, but how well the baby's pulmonary status is at longer term. I think it's wrong for us to define lung injury in the neonatal unit. I think that's just like something that we no longer do, which is like saying that, oh, this baby's neurological prognosis is not very good because we've looked at the head ultrasound and it doesn't look very good. In fact, we don't do that anymore. What we do is we say, okay, let's look at this baby or these babies at 18 months to 24 months of corrected age. And at that time, we can actually do a proper exam. We can see how the baby's doing and see if they need some intervention or not. And in fact, even then, we can't say whether the baby's got a big problem until you actually see them at 5 years of age. Then you can actually start to have a really much better assessment of whether or not their neurological and developmental progress has been appropriate. Now, we still define BPD at 36 weeks because it's much easier to do it. It's much cheaper to do it than trying to do follow-up. But I actually think that we're being misled into not doing things that we should and doing some other things that maybe we shouldn't, because we haven't looked at the long-term outcomes of the respiratory function of the babies. We've just looked at what happens up to 36 weeks. So I think for the future, we actually need to better define lung injury based on an evaluation which is later, probably at 2 years, at the same time as the babies get their neurodevelopmental evaluations. And I think what we do need to do, and I'm starting to work on this with some of the people in neonatal follow-up across Canada, to develop a sort of a scale of respiratory morbidity, which is based on outcomes that parents find important. So the first thing we're doing is reanalyzing some data that's already been collected to find out which outcomes parents find most important. And then we're going to try and construct a scale to see if we can find a way of evaluating lung injury in a way which is much more important to parents and to babies for the future. Thank you.
Wow, thank you for sharing that. It felt a little bit like a manifesto, but in a very good way. I love it. I have a clarity question, first of all, and it may show my ignorance, but there's so many terms and acronyms thrown around in NICU. What is the difference between chronic lung disease and BPD?
Well, in fact, at one time people said they didn't want to talk about BPD because it was a weird word and it was a made-up word that came from nowhere. So people started talking about chronic lung disease basically for the same thing as BPD. At one time, people were talking about them as two different things, but I think nowadays everybody talks about them as being the same thing. The BPD and chronic lung disease are really two names for two different ways of referring to the same thing.
It sounds to me like I have a personal belief. I won't blanket everything, but that sometimes in the medical world, people are over treated with good intentions behind it, but that is the reality for various reasons. And you named two good ones, cheaper and easier. And I'm wondering is that what we're seeing with the ventilation? Is it kind of this need of the medical community to overtreat what's happening, or is it genuinely helping?
Well, I think I wouldn't call it overtreating. I mean, you may have heard of this. There's a program which has provided a list of things that we shouldn't be doing in neonatology. It's called what's it called? Practicing wisely or treating wisely or something like that. And it includes a lot of things such as not doing routine MRIs of babies' heads before they go home, and not giving antibiotics if the blood cultures are negative, and a number of things like that. It doesn't specifically address any ventilatory patterns. And I think you may have a point in that sometimes I think we adjust the ventilators to make the numbers look better, we increase ventilation to make the CO2 come down, when in fact the CO2 that's a bit higher doesn't actually matter very much. And you might worsen lung injury. I don't think that, I think that's sort of some of the details of how we adjust ventilation. I don't think otherwise ventilators are really overused very much. I think most people in most centers always try and avoid to intubate and ventilate a baby unless they really have to. And sometimes we sort of wait, sometimes you might wait a little bit longer than you should. And I think that's more of an issue with ventilation than actually intubating babies who don't really need it.
It feels like this whole thing is kind of directing toward the future of neonatology, of really focusing beyond baby stay in NICU to what the rest of this person's life is going to look like.
Right.
And so you're doing some of that, I hear, through the follow-up clinics. How can we kind of change that mindset in NICUs?
Well, I think it's just something that we need to think about all of the time. I think that things like making sure the babies are growing well, making sure that we have as little lung injury as possible, making sure that we have as little brain injury as possible, making sure that all of the systems are working as best as possible. That's all should be directed to the future quality of the life of the babies who survive. And I think most of it is, but sometimes it sort of gets lost a bit. You sort of think, oh, well, we've got to reduce BPD rates, so we'll introduce this new thing. And they think, well, it's actually not BPD rates that matter in terms of that old definition of BPD. It's really how the kids are going to do in the long run. And if you can get a baby out of oxygen a few days earlier, but in the long run they end up worse, then you've not done them a favor. And I think people do know that. It's just that we really have very little data about what we can do to improve the very long term of our babies. We know, for example, now there's studies that have followed the babies into adolescence and looked at their lung function. I mean, I know some people have followed preemies up to adulthood and looked at other things, but there's studies looking at their lung function, and we know that their lung function of preemies, whether or not they actually had a label of BPD in the NICU, their lung function is not as good. You can see changes in their lung function in adolescents of 14, 15 years of age. You can see that some of them already have emphysema. And so we need to be working on that, on how we can reduce that. One of the things we really, really need to do is make sure ex-preemies don't smoke, because that's the worst thing you could possibly do, is to be an ex-preemie and to smoke. And unfortunately, in our follow-up programs, you see that once they reach adolescence, some of them do start to smoke. So I'm not a fan of vaping, but maybe that would be safer for their lungs.
It sounds to me, and correct me if I'm wrong, but like it is a difficult thing to predict. Currently, yes. We can't really tell who's going to have those issues and who's not. Is that?
Well, yes, and I think that is something we need to work more on. I think the study that was done by the Canadian network showing that if the baby's still on oxygen at 40 weeks, it's a much better predictor. But they only really looked at the most severe end of end of the spectrum of lung disease after discharge. Excuse me. And I think it would be. I think that the primary outcome of many of our trials should be longer-term pulmonary function, not BPD, because then we would know if we can improve it or not. Like I say, if you give steroids and the babies come out of oxygen earlier, but in the long term they're worse off, then we haven't really done them any favors, and we really need to know if that's true or not. Most of the studies that of the things that we try and do have never measured the longer term pulmonary outcomes. So we just don't know. They've only looked at how the lungs develop and adapt in the first until the babies go home, but then after that we don't know. And that's we really need to know a lot more about that.
Yeah, it's certainly a topic that we talk about a lot in our house, because we had a 28-weeker who in all areas she's doing very well. She's a great athlete, but she needs puffer twice a day, and it's pointing toward her prematurity. But it's those things that, I think as preemie parents, there's so much unknown that you're asking yourself when you're in NICU, what's the future going to look like? And then kind of every stage of life, you're assessing, is this related to prematurity or?
Yeah, and we know that many more preemies have a diagnosis of asthma than non-preemies, if you look at big groups. And that's whether or not they had a diagnosis of BPD in the NICU or not. It is more frequent among families who have a history of atopy, of eczema and asthma in the family. But even without that, you still get a lot more asthma. And the question has been raised of really whether it's the same disease as asthma that non-preemies get, because they probably have lungs that have been damaged by whatever helped to keep them alive. That they then have airways that are reactive, and whether or not they actually respond in the same way to the puffers, we really don't know. I get the impression that they don't respond quite as well because of the it's not just the airways that are reactive, but there's also some scarring in the lungs. So my impression is that they probably don't react quite as well to puffers. And I'm not sure about inhaled steroids that a lot of asthmatics are on, how useful they are for ex-preemies who have wheezing. I wouldn't be surprised that they are useful, but maybe they respond differently. I think it is probably a different disease when ex-preemies have recurrent wheezing than non-preemies or babies who don't have any other lung injury.
We have a question here from Jasmine. Are there any studies with surfactant injection and its long-term effect?
Yeah, there's a lot. Again, it's interesting. I've been doing this for a long time, as you can tell just by looking at me. I was around in the years before surfactant, and I was around when we were doing our first surfactant studies. So one of the things that people looked at when they first started using surfactant was the long-term effects, mostly on bronchopulmonary dysplasia, that is oxygen requirement at 36 weeks. There aren't many studies that have looked at the very long-term effect of surfactant. That, in fact, we know, in fact, it would be in some ways unethical to do a study like that right now because we know surfactant saves lives. That you're more likely to survive if you've got a surfactant deficiency and you get surfactant in the first few days. So you couldn't now do a study where you stopped giving surfactant to a group of babies. So what we do know is that there is a reduction in bronchopulmonary dysplasia, but some of the babies, by meaning oxygen at 36 weeks. And that's why people are now looking at these later treatment with surfactant. The TOLSURF study and the Christophe Roset study from France both looked at giving another dose or another couple of doses of surfactant at 2 weeks of age if the baby is still ventilated. And both of those studies look like in the long term, the babies do better, even though there's not, in fact, when we've done that a few times, and often the babies will transiently improve when you give them late surfactant and then they deteriorate again. These two studies look like when you actually follow the babies out longer term, it may be that their lungs do better in the very long term.
Well, thank you for joining us today. I think you've given us a lot to think about, and I love how we even delved into that topic of what outcomes matter most to families. And as a preemie family yourself, you guys certainly would understand that perspective. So I appreciate you bringing that to the table today.
Well, thank you. There's actually some ongoing studies across Canada trying to address those issues, which I think I'm really proud to sort of be peripherally associated with some of those studies, because I think it will in the long term make a big difference to families.
For sure. Thank you so much. We hope to see you again soon. And thank you for joining us. Thank you for participating and for letting us know you're watching and for sending through your questions. I love when we have these important conversations on Fridays. We'd ask that you visit the CanadianPreemies.org website to see this video again or any other Preemie chat. And you'll also find, like I mentioned, really great resources and information on all things neonatal. CPBF is a charitable organization that believes that through education and support, families will be empowered and ready to care for their baby. Visit their website and consider making a donation. Together, we can create a brighter future for all of our families. And join us next Friday, 1 p.m. Eastern Time again, for a very special edition of Preemie Chats. CPBF is releasing a call to action to ensure equal access of RSV prophylaxis for preemies born between 32 and 35 weeks across Canada. And I've certainly been hearing a lot about RSV this year, so it should be very interesting. We hope that you will join us then. Have a good weekend.